I'm Darrell Rigel, one of the co-directors of Winter Clinical 22. And what we talked about today is kind of critical, and that's using technology in dermatology. And what I focused on was using genomics for the early diagnosis of melanoma. I think we all know that early diagnosis is key in melanoma, and what's made a difference is genomics help us more effectively and specifically diagnose these lesions as early as possible. The 2GEP and now 3GEP tests have made a difference in our diagnosis because of the fact that they have a negative predictive value over 99%. In other words, if the test is negative, you know pretty much that really it's not a melanoma. So these technologies are just growing in use, and we really reviewed this morning. Hopefully our colleagues got a chance to learn more about it.
Hello everybody, I'm Gary Goldenberg, dermatologist from New York City. I'm here in beautiful Hawaii at Winter Clinical. In my lecture on applying technology for skin cancer management, I specifically discussed a device called Nevisense. This device allows you to use artificial intelligence, which is this device, which uses electrical impedance spectroscopy to give you a score, and you combine that score with your human intelligence, which I call your clinical skill set, to make a decision of whether or not a pigmented lesion should be biopsied, could be watched, or is completely benign and you don't need to worry about it. I use this device in my practice every day. It helps patients feel comfortable with a biopsy of a dysplastic lesion that's sort of in the middle. You're not really sure if it should be biopsied or maybe watched. I think it's great applying this device in that case. In a case where I think the lesion definitely needs to be removed and I'm really concerned about a malignancy, I use this device to tell me whether my clinical impression is correct, and if it is, I tend to take a wider biopsy to make sure that I clear the margins of the lesion right away. And then patients may come in and you may tell them, oh, this lesion is completely benign, but they may still press you to remove it. In that case, I like to use this device to show them, look, it's low risk, let's watch it. If it doesn't change, you could live with it until you're 100 years old.
Hi, I'm Shannon Trotter. I hope you enjoyed our panel discussion today. I had the privilege to talk with you more about integrating GEP, or gene expression profiling, into your management of cutaneous melanoma. It's quite daunting to think about a test and how you're going to implement it into practice. Now, commercially available here in the United States is the I-31 GEP test. What I talked about here today is a workflow, using it in accordance with NCCN guidelines, as well as AJCC staging, that you can really make it work for your practice and for your patients. You would not use it in in situ patients, but you could use it in your stage 1A patients that have challenging characteristics, such as a transection at the base or a high-risk feature. In addition, you could also use it in those patients that have a negative sentinel node biopsy or a sentinel node biopsy is not indicated. Finally, you could also use it in stage 3 patients to help inform the conversation further, potentially on adjuvant therapy. So overall, what you saw today is how you can implement the I-31 GEP test into your clinical practice so that you can help further risk stratify your patients according to prognosis.